only discuss our last two articles by Dr. Buckley, Displaced Intraarticular Calcaneal Fractures, Variables Predicting Late Subtalar Fusion, as well as a OTA highlight article discussing open reduction internal fixation compared with open reduction internal fixation in primary subtalar arthrodesis for Sanders type 4 calcaneal fractures, a randomized multi-center trial. Please feel free to keep putting in your questions, and we'll try and answer as many of them live with Dr. Buckley and Dr. Bernishka at the end.
Dr. Buckley, thanks for joining us.
Thank you.
So we're going to talk about two papers today. One, as you can see up here, is from 2003. Dr. Buckley, would you just kind of describe where this idea came from and how this idea was spurred on?
Well, this paper was generated in 2003 from data that we had created through the 1990s. And so in 1991, our Canadian Orthopedic Trauma Society was begun. Myself and Ross Layton, Bob McCormick, and Bob Meek, and Dave Petrie. And really, we put this together with a randomized controlled trial of operative versus non-operative care of calcaneal fractures. And that trial ran through all of the 1990s. And by the time everybody had 2-year follow-up, we sort of made the year 2000, presented it through around 2000, 2001, and basically determined that we had really scant differences between operative and non-operative care in a huge group of calcaneal fracture patients that will never be done again, that study, because we just can't treat them non-operatively. This particular paper then was an offshoot because we looked at all the variables that would predict late subtalar fusion in this huge group. I think it's about 470 calcaneal fractures. And so this paper then really helped us move in on what were the patient characteristics that determined someone would have a bad outcome, whether treated operatively or non-operatively, such that they'd need a late subtalar fusion. But back in the 1990s, we didn't have good evidence that operative care was the way to go with calcaneal fractures. So once we determined that operative care was probably marginally better, especially in some populations, we could proceed with this particular kind of review of our huge database. And what we found was there were certain patient characteristics, males who did heavy labor jobs. And so that was two crucial things, because when they had a bad heel fracture, especially the higher grade Sanders 3s and 4s, they had a much higher subtalar fusion rate. The people who had an initial Bowler's angle, which was much less, so 15 degrees, pretty good. It's not badly displaced. Those people had a very unusual late subtalar fusion rate. And then there was a few other things. Workers' Compensation Board patients, they just tended to have less and less ability to handle calcaneal fractures and heavy labor after, and we're much happier with subtalar fusions. And then lastly, one of the most important things we found is that, look, when you had a subtalar fusion, everybody sort of caught up to the best results that you could give them if they were treated non-operatively or operatively and were not doing well. When you fused their subtalar joint, they kind of caught up and were really doing not badly.
So you report roughly a 10% fusion rate. If you're treated non-operatively, about 20%, and then if you're treated operatively, about less than 5%. In your practice, who gets treated non-operatively and what percentage?
Yeah, thanks, Thomas. That's a really good question, and I've had to justify this for my whole career now, having been involved as the major author in this big randomized controlled trial. Non-operative care has a place, and that place is in people who are just poor surgical candidates, and especially older poor surgical candidates, and especially non-compliant older bad surgical candidates. So when you add up all those features, it's the bad medical patient, the older patient, that patient who doesn't have a bad subtalar joint, their Bowler's angle is 15 degrees or higher on initial presentation. The really non-repentant smoker, these people, when you add it together, just don't do well with surgery. Now, on the other side is if you have bad foot shape, those people must have surgery. And I put foot shape ahead of bad joint congruity because really we found that, and that was something that didn't come out in this paper, but has sort of come out since. Anybody who's got a malformed foot will do poorly. And then that makes for a very difficult late fusion. And so your question, Thomas, is important, is that those people who have good foot shape can also be treated non-operatively. We can predict who will do poorly with non-operative care based on our criteria. So if you've got a Sanders 4, right away you know that you probably have poor foot shape. You already have a joint that has been very badly influenced and its future has been determined to have early arthritis. And so putting those together, I would say that that person mandates having surgery, whether you proceed with an operative reduction, if that's something that you do, and if you don't, send them to somebody who does do operative calcaneal reductions, or a primary fusion, because our second paper really shows that a primary fusion prevents the two operations, having to do one operative reduction and then a later fusion versus just doing a primary fusion, which patients will do well. And a good thing about a primary fusion, heals up more quickly and they can start weight bearing more quickly. That's something that I think most calc fractures, when you do them, they need an extended period, at least 8 to 10 weeks. While most fusions, after 6 weeks, you've got a solid fusion and you can start walking. So I think that's an advantage.
Okay. So it kind of dovetails into our second paper regarding primary fusion. If you could just briefly describe where this idea came from.
So this paper was generated after we had done our randomized controlled trial and after we'd done our paper that we presented first there. And we had learned by this time with our Canadian Orthopedic Trauma Society that our calcaneal fracture patients, the worst, the type 4s, had a high fusion rate. Yet no one had done that paper, operative versus primary fusion, for calcaneal fractures as a study. And we thought we'd be able to generate enough within our group. As it turned out, a randomized trial was very tough, even though we had 4 real good centers operating in this group. So that was the impetus, because we knew that we didn't have an answer, yet we'd had enough cases under our belt at this point, and all of us were real calcaneal fracture surgeons. We knew we had the expertise in the group that we could do this study. So we proceeded down the line, and there'd been such a paucity of literature before about the Sanders 4. So he said, well, let's do it.
Can you just comment on how doing this paper led to additional, evidence-based articles regarding the management of Sanders 4 fractures?
Yeah, thanks, Thomas. I think it actually is a pretty significant paper, because with quality surgical care, with those of us that are involved in the study, and with a real tight group, and these are the Sanders 4. These weren't the simple calcaneal fractures, so we really had tailored it to the worst of the worst. And then when they're randomized to a fusion or to operative care, generally these patients did quite well. But we found that the results were equal. And in certainly my mind, there is a group of Sanders 4 patients that will then go on to late fusion. We didn't have that many in this study because we didn't have a lot of patients overall. But we know that the Sanders 4 occasionally will go on to second surgery, meeting a fusion. Why not do that primary fusion? And certainly, if you're dealing with a tough patient, and by tough patient, I mean maybe somebody who not necessarily compliant, somebody who's potentially a smoker, workers' compensation, they have a high rate of needing a fusion later. Why not just do one simple operation and help both you and your patient to get through this terrible, nasty insult? Now, importantly here, Thomas, a lot of people, they skip this part of the study. If we did an open reduction, that was through an extended lateral, full operative intervention. If we did the fusion, we still did the full operative intervention, but then took the joint away and fused it. And so these aren't I'll use the term half-assed surgeries. These were full open reductions followed by fusion. And I think that's necessary because we still are trying to get good foot shape. And I'll put in a plug now for operative reduction. I think by doing extended laterals, we really can create really good anatomic feet with height, length, width, all restored. I'm not a aficionado of the sinus tarsi approaches for doing difficult fractures, because I don't think we get height, length, width correct as easily unless you're really, really slick surgeon. And so this is where I believe in some instances we have to do a full operative intervention to get these bad feet, the type 4s, get them correct. And you know, these people do well. What we've learned with this particular study and even our initial randomized controlled trial was that a late fusion is not a bad outcome. A fused patient does really quite well. We know that the best patient will have subtalar motion if they've not been fused. And that is a real harbinger of their late outcome. Now, there's some more motion you can restore, and that's why the percutaneous reductions are slightly better now than the full open, because they have more subtalar motion if you've done a nice reconstruction. So more surgery means more stiffness. But if you've done a good fusion, you've taken their pain away, so they can live with a little stiffness, and it'll be accommodated through the rest of the hindfoot, midfoot, and ankle. And so a fusion is not a bad operation. It just has to be done well.
Mm-hmm. And so we'll close. The last one of the last sentences in this paper says the best treatment option is to fit the patient, not the fracture. And what are your comments on that and that statement? Yeah,
thanks, Thomas, for closing on this, because this has been something that I've really believed in for my whole career. And coming from Canada, this has been something that I think we've helped spread the word about evidence-based medicine, is that higher evidence leads to better decisions. And so the three things that make up evidence-based treatment: number one, what the patient wants, what the patient deserves because it's their foot, and what their feeling is. Because some people say, oh yeah, fuse me, doc, and get this over with, but it's the patient thoughts. Two is what the surgeon can do. What are you capable of doing and doing well to the best of your ability? And thirdly, what the evidence in the literature shows. What's the latest and best evidence? And certainly that's where we have to put the level 1 evidence and the multi-center trials and those systematic reviews and meta-analyses to the top. And we have to follow this, because we're not, none of us are better than anybody else. But as a group, we're going to move forward with higher level evidence.
Well, I'd like to thank you, Dr. Buckley, for joining us, and thank you for providing your insights from all your years of experience.